Good afternoon, and welcome to Maine Public Health Association's third webinar in our series. This is Tina Pettengill, the Executive Director of the Maine Public Health Association, and I'm so glad to see so many folks joining our webinar today. I just want to give you a couple of basics about our webinar before we get started and before I turn it over to our wonderful presenters today. Again, this is our third webinar in our series. We're very excited about the fourth webinar in our series. We're excited about the attendance and participation so far, and that continues into today. Today, our webinar is titled Shared Community Health Needs Assessment, Creating the Story About Our Data. And we'll be welcoming Nancy Birkhiemer and Jayne Harper in a moment. But just a few procedural issues to discuss. One, I wanted to let everyone know that this webinar is being recorded. We will be archiving the webinar as well as putting it onto our YouTube channel and making the slides available for folks to peruse after the webinar is over. As with most webinars, everyone who is participating is muted right now, as well as throughout the webinar. There are, though, multiple avenues to ask questions and interact with the presenters. If you look into your panel box on your screen, you'll see a chat box. You'll also see a questions box. The question box, you can ask a question at any time to the presenters, as well as so look at that questions box. We're happy to answer those questions at the end of the webinar, unless it's something that I see as the facilitator that we really need to interrupt our presenters and ask right away. We'll hold those to the end of the webinar. The other way is through the chat box. You can chat to a specific person, you can chat to a presenter, or you can chat to the entire audience, like you'll see the little missive that I wrote a couple minutes ago saying thanks for joining us. So those are two ways. The other way you can interact with us is to raise your hand. You'll see a little hand icon again in your the side panel there. You can always click on that hand, and we will unmute you when the time is appropriate, and you can ask your question live. So we will be utilizing all three of those methods to interact with our presenters today and encourage you to do so, so we can keep this as a dialogue and not just a didactic session. So again, this is Tina Pettengill, the Executive Director of the Maine Public Health Association. Again, welcome to our fourth webinar in the series. I'm very excited to welcome two leading ladies who are pulling together and leading a wonderful shared community needs health needs assessment around the state, and are doing some great work. Nancy Birkhiemer, who is the Director of Public Health Performance Improvement at the Maine CDC. In this role, she's implemented quality improvement projects and a performance management system and assists in developing meaningful measures for program monitoring. She's the lead for the Maine CDC in this project in the Shared Health Needs Assessment and Planning process, and an advocate for processes that leverage resources of multi-sector partners. Nancy has a master's in public health and epidemiology and international health from Boston University, and we're thrilled that she could join us today. Our other presenter is Jayne Harper, who's the project director for this particular project, the Maine Shared Health Needs Assessment and Planning process, providing leadership to achieve outcomes, identify additional resources to sustain the program, and generate awareness of the project deliverables. Prior to taking the role with Maine SHNAPP, she was managing the Maine General Harm Reduction Program and coordinated the first naloxone access pilot program in the state for people at risk for opioid overdose. Ms. Harper has a master's degree in science and community health education from the University of New Mexico in Albuquerque, and has her MCHAs. So again, we're also thrilled to welcome Jayne to our presentation today, and also just as MPHA, excited to be a part of a system where we're really looking at the intersection between the healthcare system, public health, and the general public, and very excited to have our two presenters today give us more information about this, tell us where things are going and how we can continue to support and promote this intersection of all of our different areas. So thanks again to Jayne and to Nancy. I think Jayne's going to kick us off. So I'm going to mute myself and ask Jayne to take us to the next step. Thank you.
Great. Thanks a lot, Tina. And thanks everybody for joining today. Nancy and I are excited to share some information about the state level Shared CHNA report. When we say Shared CHNA, it's short for Shared Community Health Needs Assessment. And we've done a preliminary analysis of the themes from community engagement input, and we wanted to share that with you also. One of the things that we're excited about with this project is it's unique in that it's the first public-private partnership of its type in the country that covers statewide health needs assessments. Our vision is to turn data into action so that Maine will have the healthiest population in the United States. And our mission is to achieve, through the shared community health needs assessment, community engagement input, and subsequent health improvement plans for the Maine SHNAPP to provide valuable population health assessment data to interested organizations and individuals, to support public health accreditation efforts, and to address community benefit reporting needs of hospitals. You can see the objectives that we hope to achieve by the end of our time together today. We will also be referring to the state report summary table. That was a document that you had access to either download or to print. So as we're going through some of this information, our hope is that you are referring to the copy of that, and sometimes we'll be referring to certain pages for some of the indicators. Tina already mentioned that you have the opportunity to use the chat or to raise your hand in case we say something and you'd like more clarification. And then at the end, we were hoping to engage this whole group and ask for some of your input about what you think based on the data that you're aware of and the data that you see through this presentation. A little bit of background, this project is supported financially and with resources from the 4 largest hospital systems shown on your screen, plus the Maine Center for Disease Control and Prevention. This has been a years-long process of communication. Ultimately, the statewide Coordinating Council for Public Health facilitated the conversation among the Maine CDC and the 4 hospital partners to work together on a unified health needs assessment and community engagement process, the result of which was the Maine SHNAPP project that was formalized in June of 2014. We have 3 steps within the process. We started out with the Shared CHNA reports. They were released on a rolling basis pretty recently. Our first series of reports came out mid-October. The state level report was finalized in mid-November. Now that we have the reports out they're pretty broad. There's 18 different health topics or domains, and there's over 160 indicators included. We wanted to make sure that people saw the report, knew how to use it, knew that they could play a role in it. So we moved to the next phase, community engagement. That started in November of last year, and it'll go on through March of this year. So the report gets disseminated, we get community engagement input, then we move to the 3rd phase of the process. Both of the first 2 phases will inform the health improvement plans. The health improvement plans are completed by the hospitals based on their fiscal year. So some hospitals will have them done by July 1st of this year. Some will have them done by October 1st. The Maine CDC will have their district public health improvement plans and the state health improvement plan completed by the end of this calendar year. So in order to complete the community engagement phase and to satisfy the requirements of the Internal Revenue Service that guides the hospitals, and to satisfy the Public Health Accreditation Board standards and measures that supports public health and gaining and maintaining their accreditation, we need to demonstrate that The public has had an opportunity to discuss the shared China data, that they've identified health needs, they've prioritized health needs, they've identified assets, resources, and gaps, and also shared perceptions of factors affecting health outcomes. This is done by a systematic communication. We've had some groups meeting behind the scenes. We landed on the district liaisons for public health, working closely with representatives from participating hospitals to form and lead what we're calling local SHNAPP community engagement committees. And in fact, what we're doing today in this hour-long session satisfies community engagement. And we'll be documenting any input that we receive from this group. The input gathered during the community engagement phase, along with the data from the reports, will inform our community health improvement plans. Ideally, we're hoping that nonprofit hospital representatives will work closely with the Maine Public Health District liaisons and those local community engagement committees I mentioned to create these implementation strategies and public health improvement plans.
So we struggled a little bit today to try to not be repetitive. We know that some of you may have been to one or more of the community forums. We're going to present a little bit of the data from some of those forums and a little bit of the data that are in the reports as well. And we're going to actually skip over some of the things that we did have in our reports. We looked at how to prioritize health issues in a couple of different ways. And one of them was looking at what our stakeholder survey had to say. We did do in April and May of 2015 a snowball survey of stakeholders. It went out to MPHA members as well as Maine CDC stakeholders and the stakeholders from the hospital systems, and we asked them to pass it along. 1,600 people did answer that survey, and we do have a list of those issues. Another way of looking at this, however, is to look at the leading causes of death, and so we decided today to share that information from the shared China. So this is overall in Maine, and it shows the leading causes with the number of deaths and the age-adjusted rates per 100,000 for each of those issues. I will say that what this doesn't get at is the health behaviors behind these leading causes of death. It also doesn't get at the socioeconomic determinants of health, or the other factors in where we live, work, and play that affect our health. So this is just what's on those death certificates, showing cancer as our #1 cause, and that's all cancers, heart disease, chronic lower respiratory disease, and then we get to unintentional injury, strokes, Alzheimer's disease, diabetes, influenza, pneumonia, kidney, and suicide. So as we looked at the data, we have been planning these forums across the state. You will see a Google map. This is shared on the Shared China website so that people can actually look up locations and dates for our community engagement events. The local community engagement committees, which are either county-based or district-based, or in some cases, I think even more local, have worked together to build the capacity to carry out these events. For each one of these events, we are asking the organizers to help us capture those notes and submit them on a form, on a web-based form, and then we were able to use that data in order to give you some preliminary results from those engagement events. Between November 4th and December 31st, we had 17 events. We received 13 reporting forms. Some of those other 4 we've received since then. And so we had forums that we're reporting on today, 2 in Aroostook, 2 in Washington, 2 in Penobscot, 1 in Piscataquis, Hancock, and York each. And then we had group presentations, and these were not necessarily open to the general public, but were a more focused audience. The Tri-County Mental Health Board of Directors, Androscoggin Chamber of Commerce, the York Public Health Obesity Work Group, and the Choose to Be Healthy Advisory Board. So you can see that the northern part of the state did get their forums going a little bit early than some of our southern community forums, but you'll also see the group presentations balance that out at least a little bit. I should also mention that we had a total of 376 people who attended those events. So with those 376 people, we had we asked them to identify what sector they came from, and you can see on this slide that and this is the percent of events with representation from these different sectors. So every of the 13 events, every single one had somebody who was either low income or represented or served people from those. And so examples were community action programs, United Ways, healthcare providers who focus on low income people, WIC, SNAPP Ed program staff. We had a lower representation for minorities, racial and ethnic minorities, but some examples there, the Wabanaki Public Health, the Maine Migrant Health Program. For medically underserved, and this is defined for us as populations at risk of not receiving adequate medical care as a result of being either uninsured, underinsured, or having geographic, language, financial, or other barriers. And so again, FQHCs, Tri-County Mental Health, some of the service providers, advocates for children, identified them as people who served these populations and represented their needs. And then you can see other sectors in which we've had representation at these events. We also tried to capture what type of input we were receiving. So at all of the events, we've been discussing the data. Most of them we've been identifying health needs, assets, and resources. A few of them they've gone through some exercise to prioritize health needs. And some of the other areas were identifying barriers or next steps. Oops. So what we're going to share today is some summary information on the topic, on some of the top topics of breakout sessions of these community forums, what resources and assets were identified, what is needed, what are the barriers, gaps, and solutions or next steps. And at each of these forums, we've also given people an opportunity to write down some of the things that they felt were not necessarily getting fully discussed due to time or the structure. So we'll talk a little bit about what came out in those comments.
So we ended up looking for common themes within the most frequently cited health issues as topics of breakout sessions. So where you see a number in brackets, that's the number of breakout sessions among the 13 forums that took place that this topic was discussed. And what we're going to do now is, as part of the focus of this webinar, is we'll show these health topics. We'll just do a brief fact and refer to the location in the summary data sheet where you can find the list of indicators for that health category. And then we'll move into the findings from, or of the themes that we were able to identify from our qualitative analysis of the input. So first we'll look at obesity, and you can see on the left-hand slide on your screen we're looking at the obesity reported as a percentage of adults per county. The percentage of obesity across the state of Maine is 28.9%. On the right-hand map of Maine, that is the percentage of obese high school students in grades 9 through 12 as reported in the Maine Integrated Youth Health Survey. The total for the state is 12.7. If you're following along on your summary data sheet, it's on page 5 or the last page under the heading Physical Activity, Nutrition, and Weight. So then we took the information from the reporting forms from these sessions. We looked first at resources that could be used in combating obesity, and we had four comments most noted about resources. First, what had to do with access to outdoors and trails and indoor activities. Second, resources, schools providing activities for students as well as working towards using healthier foods in school lunches. Third, access to healthy food through farm stands, farm shares, and local community stores. And fourth, hospital and community health center programs. Next, we looked at barriers in combating obesity. There were 5 that we were able to identify. First was access and affordability to healthy food. Second was transportation to activities or options and access to childcare for adults to go to the gym or do other physical activities. Third, we were looking at access to further education on healthy eating and healthy cooking. Fourth, food pantries not supplying healthy food choices. Fifth, less access to dietitians and healthcare systems to promote change in habits. And finally, we were looking at some of the solutions and next steps in combating obesity. We had four areas identified. First was education and community hubs such as grocery stores, including cooking classes and access to dietitians. Second, health insurance incentives in workplaces and in schools. Third, opportunities and collaboration between nonprofits and health systems. And fourth, food pantries partnering with other entities for healthier options and education. Our next health topic is drug and alcohol abuse. This was also noted at 7 different breakout sessions. What you see is we pulled out some of the indicators. That is also on the 5th page of the summary data document. And these are the indicators reported as a percentage. You just have them laid out there for you so you can see the results for Maine that come from the Behavioral Risk Factor Surveillance System or the Integrated Youth Health Survey. And then we looked at the information that was submitted as input from the reporting forms. A similar thing, we looked at resources in addressing drug and alcohol abuse. There were some themes, lots of different agencies, organizations, programs were identified. They fell along the categories of prevention, treatment programs, recovery supports, and community supports. People were very well aware of what was available. Then we got into the barriers of addressing drug and alcohol abuse, and some of the most common ones had to do with, while people knew what programs were available, there were issues of not enough funding or money, not enough law enforcement. And with regard to not enough law enforcement, a couple of these forums took place in Washington County, and they wanted to make it known that they need more law enforcement professionals to complete investigations, and that there's only one drug enforcement agent working in all of Washington County, but you need 2 agents to complete a bust. Other themes for barriers related to attitudes and culture, youth issues, which covered schools don't have the time and the curriculum or resources to carry out evidence-based programs, the need for prevention programs in younger grades, the lack of treatment resources for youth, lack of school resource officers, and lack of constructive activities. Treatment issues, not enough services, not enough access, not enough options, and limited reimbursement for providers. Lots of need for education, and then the social determinants, or what we're calling the health factors: lack of jobs or employment training programs, lack of transportation, lack of housing, isolation in rural areas. And then solutions and next steps for addressing drug and alcohol abuse lie in securing funding, coordinating efforts among the resources that are available, and making sure that everybody's working to maximize, with either create or maintain the local task forces in place, the medical community consistently prescribing opioid medications and recruiting Suboxone providers, and investigating reimbursement issues, and changing legislative policies, and keep talking about it to reduce stigma. Our next health issue is mental health. The map you see shows the different percentages of adults with current depression in Maine. The darker the color, the higher the percentage. This is on page 4 of your summary data sheet, where all of the mental health indicators are located. And then when we looked at the input from the breakout sessions on mental health that we have, resources were identified, many naming specific organizations, as well as partnerships with schools, law enforcement, and primary care providers. And then there were lots of gaps and barriers identified. Top were the availability of services, the availability of inpatient beds, funding, geographic isolation and transportation issues, stigma, education and awareness, and health insurance coverage. Our next steps include developing a sustainable, prioritized action plan, which might include legislation on some issues. And suggestions for leadership included many local behavioral health organizations, NAMI, along with state government.
So the next issue in the themes that we were looking at, the community engagement breakout groups looked at, was tobacco. So this is the map of percentage of adults who smoke, and this is aggregated across 3 years from the briefest. And I'm sure this is data that many of you are familiar with. In terms of resources identified during the community engagement forums in addressing tobacco use and cessation, the local prevention programs in the form of Healthy Maine partnership activities, policy and environmental supports from taxes, the No Butts program, tobacco-free policies were identified, as well as community-based and healthcare-based treatment options. There's a lot of discussion on coverage for nicotine replacement therapies, health lines, local healthcare centers with smoking cessation classes, employers with policies against smoking, as well as health plans that cover tobacco cessation or internal tobacco cessation programs, and the accountable care organization requirements for screening for tobacco use, and providing triggers for providers to work with patients proactively. Barriers to addressing tobacco use and cessation were identified in terms of family history and children being in homes with smoking, inconsistent levels of education and messaging, so needing to more consistently inform the public about local resources, as well as I think smoking in general. Issues around culture and language, and including Native American cultures. Resources are often only in English. Some of the needs for long-term interaction versus short-term solutions, and trying to improve the access and find additional resources. So some of the options are not robust enough or accessible enough, not having a primary care provider or a primary care provider who knows the resources, and the out-of-pocket costs or limited coverage, high deductible insurance issues for nicotine replacement, and then lack of enforcement of policies. And finally, the solutions in addressing tobacco use were identified as the more barriers that we can create, the better, and the need to work across community borders and across, and I think that also extends into accessing tobacco outside of the state, creating an organized approach for everyone being on board, and continuing to integrate currently available resources into current public health and healthcare delivery channels. Finally, we looked at, we had a number of groups that looked at diabetes. So this is the diabetes prevalence in Maine as well as the pre-diabetes prevalence. And resources identified for diabetes were, a lot of them identified were around hospital systems and providers, but there also seems to be some segmentation and not a lot of coordination between organizations. Focus on pre-diabetes and education around healthy cooking, eating, and obesity prevention, and many of the these resources as well as barriers mirrored some of the comments that were raised in the obesity section as well. The largest barriers were a lack of cohesion between health systems and within a lack of broader educational opportunities. There are some concerns about general health literacy and people not being able to make healthier choices or have the means to do so because of some of those barriers. And then poverty and access were noted as barriers as well. The solutions presented included promotion of work that was already being done at hospitals to foster collaboration and connection to mental health services. There was some discussion of integrating health coaches into health systems more consciously and pushing larger scale educational campaigns on both social media and traditional media. And then finally, there was a lot of, a number of comments around telemedicine in this area. So the parking lots that we gathered, these were opportunities for folks to comment on things that weren't covered in some of these top areas that there were breakout sessions, discussions on. And the themes of these sort of split out into 4 areas: surprises, other possible priorities beyond the ones that were presented, more data that are gaps in the data and the resources available. So some of the things that surprised people were to see higher rates of lead poisoning, high rates of teen pregnancy, and I think that varied from the location, asthma emergency department rates, and the older population, and this was in particular related to overweight and obesity statistics, but I think in general as well. Some of the other possible priorities included dementia and caregiving support, respiratory diseases, specifically depression and stress, teen pregnancy, early detection of childhood disabilities, concerns about environmental health issues like arsenic and lead, domestic violence, cardiac disease, cancer, advanced directives and proxies for healthcare and Lyme disease, chlamydia, gonorrhea, and then a couple of populations, women and youth were specifically mentioned. Socioeconomic factors must be addressed was a theme that came out in this area of possible priorities, including poverty, lack of education, health literacy, and insurance issues. And then some strategies of how we might approach things were listed as priorities, including policy, access to specialty providers, and identifying consequences of some of the work that's unintended consequence of work that's being done. There's an identification that we need more data on trends than we have provided, and we actually have identified that as an area for the next CHNA to definitely make some significant improvements on. Hearing loss, linking poverty more extensively into the data, pediatric disabilities, overall birth rates, more age information about substance abuse, and information for people with disabilities. And then around resources, we saw some comments for specific issues, additional resources that might not have been captured in breakout sessions, for example, around lead and substance abuse. We also heard or got comments around a lot of specific action steps for future community improvement plans and need to continue to collaborate. So those were our sort of what we've received back in that first 6-week period of community engagement processes.
So we're real interested in hearing from you. We have 2 questions. First, we have this one about, after briefly doing the overview of these topics, from community engagement and also Nancy's sharing the leading causes of death, are there other indicators or issues you feel should be prioritized? If so, what and why? I'm also aware that we've been doing a lot of talking, so if team has gathered any questions specific to some of what we presented, we'd be glad to answer those right now also.
I haven't seen any questions yet, so folks are welcome to raise their hand, like I said, or they can type a question into the question box.
And if nobody has any questions about what the information we've shared, we are very interested in learning your input about any other indicators or issues that you think are important, or to just reinforce some of the information that you've already heard if you think folks are heading in the direction that you believe they should be heading in. The other question that we wanted to pick your brains about was to learn from you any recommendations you have for turning data into action. So we would love to open it up for that also.
I do have one question, and that is from Jonathan asking, are any of these results from tribe or tribal communities in Maine?
We have had input from our tribal liaisons to the process. Both the Maine Integrated Youth Health Survey, the Behavioral Health Risk Factor Survey, our census data, our death and birth data all include people who are in tribes as well, but we do not have any specific tribal information at this time. It's my understanding that the Wabanaki Public Health District is looking at how they might go about updating their last community health needs assessment that was, I think, done in 2011 as a process that they are working on. And one of the things that they have remained very committed to is having a very community participatory approach to that. But that is a and so they're seeking out resources in order to be able to do that, is my understanding. So this assessment does not exclude them, but and we do have some data analysis by race that includes, by Native American Indians, but it doesn't have tribal specific data.
We have a quiet group today.
I'm wondering if any of you who are on the phone have either attended a forum or are planning to attend a forum and have any thoughts about what you would like to see happen either in the forums or as a result of these forums. And again, you can chat, you can provide input via the chat box or raise your hand, and Tina then can unmute you.
We do have one question from Caroline asking, was there anything that came up in your community forums that surprised you or was unexpected?
I think this is Jayne. For me, when I think about the forums that I've attended so far, I was surprised by the level of engagement and connection among the people who've attended, where they've all had small group breakout sessions to talk about these topics, and at every single one of these that I've been at, it's been really exciting to see how committed the people are that come to public health and making improvements in their communities. Not that it was surprising, but it was just refreshing.
I think that, again, not entirely surprising that there has been a fairly consistent resonance with what our stakeholders have said, that essentially that maybe what has surprised me is that there hasn't been more dissonance around what's important, that sort of the data and the stakeholder opinions and the community participants have all been relatively in agreement, relatively strong agreement as to what's most important. That said, I think that there are times when I've been a little bit surprised that other issues haven't come up, and nothing in particular, but one of the things that we have noted is that cancer is our leading cause of death, but that has not been widely seen as a missing piece in our discussions. And that's possibly because as we look at population health, people are looking more at the prevention aspects of it that get into health behaviors versus treatment or even screening.
We have another question about the data, overlaying the data, the population data from the multiple sources that you referenced, and the qualitative information from these sessions. What are your plans to intermix the two?
Well, that's a good question. I'm not sure we have a firm plan. This was our first attempt to do so, to really try to capture some of what the community engagement folks were saying and synthesize that into something that was a little bit more, that we could identify themes across the state. I will say that many of these community engagement forums, the participants got very specific about what the resources are by naming agencies, and I think in a few cases even individuals who had something to say. So I think our plan is to continue to figure out how to synthesize the data and bring it together. The community health needs, the shared China reports that are currently available on the Maine CDC website will remain as they are, but the engagement piece and the qualitative data will then be used in the process of developing the improvement plans by both the hospitals and the districts. So we do intend on making that information available and actually have done so in the forms of summary reports for each of these sessions. But they may not actually get well integrated other than in presentations such as this.
Nancy had mentioned at the beginning of the presentation about the stakeholder survey that was done mid-2015, and the results from the stakeholder survey, some of which was qualitative, were woven in as much as they could be into some of the findings with the quantitative also. And I think part of what we noticed is there's not a huge difference in what we were finding with the stakeholder survey results and identification of resources and some of the barriers and what we're finding in this community engagement input also.
But we are seeing a deeper dive into a lot of those, I think, in a broader group of people being engaged.
I have another question here from Nancy. I just wanted to thank you for the data and reinforce my observations as a clinician that the social and economic stress on the families really impacts strongly on their ability to work with me on treatment process. So all the assistance / education from the community will have a positive impact. Thank you. And I guess that was a little more of a comment and compliment. A question from Bethany: are these results going to inform funding or policy decisions in any way, or plans for this at a state level?
So our plan with this is that during the community engagement we are collecting this information. We will use that and the information from the hospitals on their implementation strategy to help inform our next round of district public health improvement plans. That will inform our state health improvement plan. And I have to say that we haven't yet had the full discussion on what we will be doing regarding resource allocations based on the next shift, but I think it will come through that mechanism most likely.
Okay. And another question from Cindy asking, one surprise that came up in one of our forums was issues related to hearing loss that can lead to non-adherence and other issues. I guess that was not, again, a great comment.
And I would add to that that was brought up in a couple of different places, I believe, and that one of the things that we identified in another forum was vision loss as well, and that we don't have a lot of data on either of those issues or on other specific disabilities within our shared China, and that may be an area that needs more exploration at some point. I will say that it was a huge challenge in our shared Chinas to come up with a reasonable number of indicators that were comprehensive enough, but also within our resources to analyze.
Part of what we were hoping to do is to have large enough data sets that we could break down the information at the county level. So not only would it be useful for the state, but for either the hospitals serving a county or federally qualified health centers or United Ways or community action programs. So that has been a stumbling block, but part of this process is to get the these comments and to have it inform what we do the next time. So keep the comments and recommendations coming, because it does help make this even better and more useful to a larger number of individuals and organizations.
With that in mind, and we still do have a few more minutes for questions, I don't want to cut those off, but I did want to share our contact information as well as the location of the shared China reports. And on the Maine.gov SHNAPP website, there's also a comment form there that will allow us to continue to gather feedback from you all, or anybody who chooses to go there and leave comments or questions. We are, in addition, collecting, trying to do a frequently asked questions document on that website, so that should you have questions, that can be one resource to get more information.
And please feel free to contact Nancy or I afterward if you come up with some questions or comments. We're always accessible.
Although I now look at my phone number and I think we have a typo there. I didn't double check this. So my phone number is 287-5716. We'll make sure that gets corrected before the...
Yeah, we won't. We'll correct that before we upload it. I wonder whose phone number that is. Well, I'm not seeing any other questions in the queue here. If anyone does want to raise their hand, we're happy to unmute you and have you ask. And you also have Jayne and kind of Nancy's contact information up there. Maybe an email would be better in this case. And I'm sure either one of them will be happy to respond. We'll give you guys another maybe 15 seconds if anyone wants to shout out and ask a question. Nancy or Jayne, do you have any last thoughts before we part?
Thanks for the opportunity to share with you today.
Oh, wait, we just had another question come up. Oh, apparently that's Paula Thompson's phone number, or Thompson's phone number.
Oh, sorry, Paula.
Nancy, will you repeat yours one more time?
287-5716.
Okay, got it. Well, thank you again to both of you. This has been really interesting information and engaging discussion. So we look forward to the next steps in this process and coming together as our various stakeholders to see where how we can move this forward. So thank you again, and thank you also to our participants today, and we'll look forward to seeing you on our next webinar or through social media or through MPHA membership communications. Thanks again.